How you doing, Sean?
I'm good. It's good to see you, Phil. It's been a while since we've talked, but it's great to have you. For those who don't know, Phil's been a part of this community for a long time now. He's done quite a bit of stuff with our research, and he is well. Let me give you your background, Phil. Introduce yourself. You're a cardiothoracic surgeon, but tell us a little bit about yourself, if you don't
Sure
mind.
thing, Sean. Great to be back here with the community. As you said, I'm a cardiac surgeon. Been in practice now for about 15 years. And over the past 5 years, I've been on my own sort of personal journey towards improving my health. And that was largely with a carnivore diet. And I have now sort of added a new dimension to my career, refocused a little bit on helping people to avoid the need for heart surgery and to stay off my operating table. I got a new book that just came out yesterday called Stay Off My Operating Table, and love to kind of share the thoughts from it with the community here.
Absolutely, yeah, that's great. Well, do me a favor, Phil, if you don't mind. I'm assuming, one of your more common procedures were cabbages. Is that correct? So, what can you just walk me through that? What is a normal person going in to get a coronary artery bypass graft? What's it like? What do you got to do? What's happening there?
Sure thing. Yeah, the most common operation that I perform as a heart surgeon, that most heart surgeons perform in this country, is called the coronary artery bypass. The acronym CABG is what it's commonly known at. And that's for people who have developed blockages in the arteries of the heart, and they are not getting adequate blood flow to certain areas of the heart that can lead to having a heart attack, or it can be sort of a less, sort of severe but more chronic problem that we call angina, where, people get chest pains, is the classical finding. And, sometimes blockages in the arteries can be dealt with stents, which is kind of a minimally invasive procedure. But when it is progressed beyond that point is when people might need the open heart coronary artery bypass surgery that I perform. And that's a pretty involved operation, typically, about 6 hours in the operating room, between 5 and 7 days in the hospital afterwards. We usually have to split the patient's breastbone to get to the heart to do that operation. And the recovery from that can be pretty intense, 6 to 8 weeks of limited activity. And patients are typically very tired for, 2 to 3 months afterwards. And although, most patients recover from it well, some patients don't. We've gotten very good at doing that operation, but it's still about 2 to 3% of the people who have that operation don't survive the operation or don't make it out of the hospital alive. And, there can be some long-term complications that occur after it. So ultimately, what I've come to realize is no matter how good I am as a heart surgeon, no matter how good all the other heart surgeons are out there, we can never make the patient as good as if they didn't need the heart surgery in the first place.
Yeah, so you crack the chest open, you cut through the sternotomy, where you cut, you said the breastbone, you basically saw it in half, open the chest up, and then you're taking veins and vessel, arteries or veins from different parts of the body, correct? To replace the ones that's blocked up, correct?
Yeah, exactly. We're basically rerouting the blood around the blockages. And to do that, we use typically some veins from the leg or some arteries. There are some arteries inside the chest that we basically repurpose. Sometimes we use some artery out of the patient's arm as well. But it's a very involved operation. I think most physicians will talk about, heart surgery is kind of one of the big ones that goes on in hospitals on a daily basis. And although it's a very common operation these days, approximately 500,000 to 600,000 procedures done in the United States every year, it's a big one, and it's one that ultimately people would be better off not having.
Who's the typical consumer of cabbages? What does the average person look like that you're going to put on the table and bypass their arteries?
Yeah, and this has been something interesting that I've seen over the course of my career. I've been, my training and now in practice for 15 plus years. When I started my training about 20 years ago, the patients were typically in their 60s, 70s, even their 80s, and they were a mix of people who were obese, overweight, but plenty of them are not obese or overweight. And, traditionally, we've been told that, the top risk factors for developing this problem are smoking, which is certainly true, and then having high cholesterol. But it turns out that many of the patients I ended up operating on did not have high cholesterol. And that was always kind of in the back of my mind as I was going through this. Now, today, 20 years later, it's actually shifted. I am routinely operating on people in their 40s, their 50s, and even occasionally someone in their 30s for these problems. So clearly we're seeing these problems develop earlier. And, what I have now come to recognize is the number one risk factor for this is, poor metabolic health, insulin resistance. Type 2 diabetes is very common in the patients that I end up operating on. And, as we know now, these are preventable problems. These are reversible problems. So what I have come to realize ultimately is that every patient that ends up on my operating table is a patient that the healthcare system has failed. The vast majority of these cases, could have been prevented if we were paying attention to the proper things.
So Phil, what you're saying is, some of these patients may have high cholesterol, some may have normal, maybe some may have low cholesterol, but all of them have in common metabolic derangement of some sort. Is that fair to say?
Yeah, exactly. And we have some pretty good data on this, especially when you go back to the literature before cholesterol became such a focus, the 1980s, the early 1990s. It is almost universal that patients that are having cabbage have some form of metabolic dysregulation, derangement. They might have overt diabetes, or they just have diabetes that hasn't been fully recognized yet. And that's almost universal. Whereas the cholesterol question, having a high LDL cholesterol is not nearly universal. It's probably only about 50 to 60% of the patients. So, that along with lots of other evidence, that we have shows that, metabolic disease is really the central problem. And unfortunately, we just don't deal with that as a healthcare system. We ignore that.
Clearly, when as I've, many cardiologists point out, when they go in and, cut out, atherosclerotic arteries and replace them with, when they put them under the microscope, there's cholesterol, there's foam cells, and, cholesterol within the atherosclerotic lesion. So how does that jibe with, what is the pathophysiology that's ultimately going on, and how does that progress to atherosclerotic cardiovascular?
Yeah, cholesterol certainly plays a part in the process that is leading to heart disease. You're right. When we look at these plaques, these blockages that occur, there is cholesterol in them. But, I think a very good analogy that I stole from Dave Feldman is that, when if we were aliens looking down on the earth and we noticed that every time there was a building on fire, there was a fire truck with firemen next to it, we might think that the firemen are going around setting buildings on fire. But the reality is that they're there to put out the fire. And cholesterol is there as a repair mechanism for the damaged blood vessel. And the primary inciting event is damage to the blood vessel. And that can occur, from inflammation of any sort. Metabolic disease, high blood sugar levels is, one of the most common things that causes that damage in the first place. Smoking is another common cause of that damage in the first place. But rather than trying to, lower the cholesterol and kind of interfere with that repair mechanism, we would get much better results if we were focused on what caused the damage to the blood vessel in the first place. And that, for me, comes down to metabolic health.
Yeah, I mean, and I imagine, the lion's share of prevention, again, goes with this atherosclerotic disease. But, as a heart surgeon, I guess I'm sure you do some other procedures as well. What other cardiac diseases are there that, might have a degree of prevention that you can avoid?
Yeah, so the opening story of my book is a unfortunate young lady who came in with what we call an aortic dissection, a tear in the blood vessel leading out from the heart. And that is a devastating problem. It is a surgical emergency. It has a very high mortality. Many patients don't even make it to the hospital with that condition. Those that do, need to go to surgery right away. And unfortunately, that surgery, still has a very high incidence of people not surviving. And the unfortunate young woman that I opened the book with didn't survive that operation. But that condition is clearly related to, uncontrolled high blood pressure, which is another hallmark of poor metabolic health. And if we were to, realize the root cause of high blood pressure in most cases is poor metabolic health, and address the poor metabolic health, this is another condition that can be largely prevented. And then honestly, there are a fair number of surgeries that I do for problems with heart valves. Some of those are related to metabolic health. Most of them probably aren't related to metabolic health. But what I tell my patients is, if you are metabolically healthy going into a major operation, such as an open heart surgery, you're going to have much better chances of coming out of it, well. And so while the causes of the surgery themselves might not be related to metabolic health, being metabolically healthy is still going to put you at a much better place if you end up needing that surgery.
None of us want to have open heart surgery. I wouldn't sign up for that. There's very few surgeries I'd sign up for, but certainly not that one. Okay, your book's called "Stay Off My Operating Room Table." So I assume there's some way that you suggest to keep people off the table. How do you, if somebody is, if you're to look at somebody, either, based on their history, based on lab numbers, who are the people you're really concerned with? And then how do you keep them off your operating room table?
Yeah, so, what I have come to realize over the past couple of years, as I went through my own journey of improving my metabolic health, is that metabolic health is really the most important risk factor for heart disease and for most of the other chronic diseases that we face. And I know this is well known to this community and something that you talk about often. So for me, I think what we need to do as a healthcare system is refocus our efforts towards metabolic health. And for individuals out there, if you want to give yourself the best chance of not ending up on my operating table and of remaining healthy, throughout your lifespan, focusing on your metabolic health is the best way to do that. The problem is that we don't recognize, what metabolic health is. Most doctors don't know how to measure it, don't know how to assess it. They might have all the information in front of them, but they're focused on the wrong things. So they don't see that pattern of metabolic health, and therefore they don't address it early enough.
So what is the pattern that you see, Phil? What are you looking at? How would you say this person's metabolically unhealthy? Obviously someone's a diabetic, you're pretty much, okay, that's a pretty big red flag, but what are you looking at?
Yeah, so there are 5 basic metrics that I look at. And again, these are the very basic first steps, but if everyone knew these 5 metrics and paid attention to them, we'd make a lot of, progress. So those 5 metrics are your waist circumference. Very simple, measure it at home, take the tape measure just above the level of your belly button, measure it the first thing in the morning. And if you are a male, you want that to be less than 40 inches. If you're a woman, you want it to be less than 35 inches. The next metric we look at is your blood pressure. Again, you could check it at home. You can get it checked at, any grocery store or pharmacy these days, or you can go to your doctor and get it checked. And you want your blood pressure to be less than 130/85, and that needs to be without the use of any medications. If you have been started on medication for high blood pressure, that is an indicator that you are not metabolically healthy. And then we look at some blood work, pretty basic blood work. Almost every physician gets these as part of a routine physical examination. Again, they just don't look at it in the proper way to interpret it. But we want to look at your fasting blood glucose level. And again, without the use of medication, that needs to be under 100 milligrams per deciliter. These are all the US units. If you are type 2 diabetic, if you've been started on medication to lower your blood sugar, you are not metabolically healthy. And finally, we look at the cholesterol panel. But importantly, we don't look at the LDL cholesterol, the so-called bad cholesterol that every physician is singularly focused on. We want to look at the other two measurements on that panel. Your HDL cholesterol, your so-called good cholesterol. As the nickname implies, the higher, the better for that. If you're a woman, you want that to be over 50. If you're a man, you want it to be over 40. And finally, we look at the triglyceride level, and you want that to be less than 150. So you look at those 5 measurements. If 3 of those are not within the healthy range, you have metabolic syndrome. It's actually an official medical diagnosis, and it means that you are at very high risk for things like diabetes, heart disease, Alzheimer's disease, many types of cancer. If you only have 1 or 2 of those abnormal, it's a warning sign, though, because we know that you are likely to progress to have 3 of those abnormal at some point in your life. And if all 5 of those metrics are where they need to be, if they are within that healthy range, congratulations, only 12% of the adults in the United States can meet all 5 measures of optimal metabolic health. So, that is my measuring stick. And, when we start talking about the diet and the lifestyle interventions that might improve that, those I think are the basic measurements that we should be looking at to assess whether we are, moving in the right direction or not.
How much of the literature, with regard to heart disease out there confirms what you're saying? I mean, are there a number of studies you can point to and say, increased incidence of atherosclerotic disease and, metabolic syndrome? Is there a pretty robust amount of literature on that?
Yeah, there is. Most recently, a few months ago, the Women's Health Initiative, some of the new data that came out of that looked at the risk factors for heart disease, and having an elevated LDL cholesterol by itself was found to be a small risk factor for heart disease, 1.5x basically the risk of heart disease in someone who had an elevated LDL cholesterol versus someone who didn't have an LDL cholesterol elevated. When you look at metabolic disease, and in that study, they looked at insulin resistance, which is one of the measurements you can use to assess metabolic health. If you were insulin resistant, if you were not metabolically healthy, you had about a 6x risk of heart disease. So, cholesterol, as I said, plays a part in the process. It may be a minor risk factor, but metabolic health is clearly the major risk factor. And, this recent Women's Health Initiative data confirmed it, but there have been many, many other studies throughout the, medical literature that you can find that show that poor metabolic health, insulin resistance, elevated blood glucose levels are the major risk factor for heart disease.
So when you're making the decision whether to bring somebody to the OR or not, I mean, I'm sure it's based on symptoms and, the degree of blockage and so on and so forth. Is there a point where you say this can be managed with lifestyle? And, and if you do that, does the lifestyle show that it can improve the overall situation?
Yeah, so, typically the way the healthcare system works these days, by the time the patient gets to me as a heart surgeon, they're usually, at the point that they need surgery. their cardiologist, their family doctor has been managing them, prior to that. So oftentimes, it's kind of too late for that lifestyle intervention. What we know is that, we don't have very good evidence that we can undo blockages that are already there with diet and lifestyle. There's a little bit of suggestion of that in some studies, but for the most part, we can't undo the damage that's already been done. But if it's recognized early enough, if it's recognized before it gets to that point, we can certainly intervene. We can stop, additional buildup of blockages. We can stop additional damage from being done. And so that is, why I have taken on this new focus. I have, now a telemedicine practice that I work with people to, get to them early to prevent it from getting to the point where they need to see me as a heart surgeon.
Yeah. So just as a point of curiosity, what sort of interventions are you end up doing lifestyle wise? I mean, I'm sure diet has a role here. Are you putting them on the Dean Ornish diet because they claim that that's the only thing that can reverse heart disease, although that's highly debatable. What are your thoughts on?
Exactly. The data around that was questionable, but yeah, I think the diet is the most important factor here. And I think, the central sort of theme that comes through in all the diets that seem to lower the incidence of heart disease is eating whole, real food. And I think ultimately, that is what is going to give us the best chance of being metabolically healthy. Honestly, there might be some debate about, whether it should be, all animal products, all vegetable products, or somewhere in between. Personally, and, I consume, the vast majority is animal products. But I think ultimately just eating whole, real food is the best first step for anyone to take. Eliminate the processed food, eliminate the vegetable and the seed oils, these fake oils that have only recently been introduced into our food supply, and on a cellular level, clearly damage our metabolic processes, our metabolic health, and just focus on eating whole, real food. And that's going to go a long way towards getting you metabolically healthy. Now, there are other factors. In the book, I outline the 7 principles of metabolic health. And there are other things like, moving more, sleeping adequately, dealing with your stress. Those all play a part in it. But ultimately, what I tell people is, what you are eating is the primary determinant of your health.
Yeah, remind me where you're located again. I know you're in Florida, but which part?
Yeah, so I'm in the Tampa area in St. Petersburg, Florida.
Right now, I'll be in your neighborhood in about 2 weeks, so maybe we can meet.
Let me know. Yeah.
Yep. So I'll be there from the 20th to the 27th. So I'm looking forward to spending some time in Tampa. Obviously this is a pretty radical departure for a surgeon. Obviously, I'm sure you enjoyed surgery. I'm sure you get a thrill. I mean, there's a thrill. I mean, you've probably done so many of them now where the thrill is kind of gone, it becomes routine. It's not, you like surgery to be, ideally it's boring, that's my goal, to make sure the surgeries were boring, because that means everything went fine. But do you get a greater sense of reward now, being able to prevent these surgeries, or is it still more enjoyable to do the procedures?
Yeah, I would much rather, prevent people from needing the surgery ultimately. You are right. I do enjoy doing the surgery. I feel blessed that I can offer that to people who need it at the time that they need it. But as I said, I now realize that pretty much every patient I operate on is a patient that has been failed by our medical system. And we need to do a better job of preventing this. And I would much rather, keep people from needing the operation. Ultimately, I always say I'm a horrible businessman. I'm trying to put myself out of business. But if it truly were to come to a day where there is no more heart surgery to be done, I would consider that to be a great success.
If you were put in charge of the entire healthcare system and you wanted to focus on preventing heart disease, what would that look like? How would you roll that out?
Yeah, so I think first and foremost would be fixing our food environment. We live in a toxic food environment. All of these processed foods that have been, created in the past, 150 years or so, are clearly worsening our health as a country. And, you can argue about, what component of the food it might be. Is it the carbohydrates? Is it the vegetable and seed oils? But my argument is it doesn't really matter, because usually these foods combine both of them. And so it's hard to separate the two of them. So I think, if we could just get back to eating whole, real food, that would go a long way towards improving the health of our society. And, this becomes a very important issue, currently. It is quite clear that, the current pandemic that we are involved in is due to poor metabolic health. The very earliest data that we had, around COVID was that it was primarily affecting people who were not metabolically healthy. And that unfortunately has been ignored for the past, coming up on 2 years now. You don't hear the public health officials talking about it. You don't hear the politicians talking about it, certainly. And, if we want to get out of this pandemic and make sure that we don't end up in another pandemic, pretty soon, we're going to need to do something to address our metabolic health as a nation.
Yeah, and I think, one of the things when we look at, regardless of how you prophylax for this stuff, we see the people that are, having breakthrough cases that have been vaccinated. These are the metabolically unhealthy people, the same people, or the vaccines or the immune system just doesn't work as well, regardless of that. And so we just kind of totally dropped the ball on that for sure.
Exactly.
All right. So what, your colleagues, I don't know if a cardiothoracic surgeon are not super common. So you don't, unless you're with a giant specialty group, you may not even run into a lot of cardiothoracic surgeons, but I'm sure you know a lot of cardiologists, I would imagine. So what is a general thought among the community, among your colleagues and those that are similar to you?
Yeah, the general thought in the community is, that this is, this is crazy talk, basically, that the only thing that we can do to prevent heart disease is, have people not smoke and lower their cholesterol level, with medications. And so, when you talk about, eating whole, real food as a way to prevent heart disease, it's just generally dismissed and not paid attention to. But I am, starting to get encouraged. We do see more cardiologists, more physicians in general that are starting to talk about this, starting to pay attention to it. I go to, some of the meetings, and, I see doctors from more and more specialties. I see more cardiologists there that are starting to come around to these ideas. It's clear what we are doing now is not working. Heart disease has been the #1 killer in the United States for the past 30 years without any noticeable change. And, for 40 years, we have been telling people to eat low-fat diets, eat according to the US dietary guidelines. Statin medications have been the most prescribed class of medications for the past 30 years as well. And despite all of that, we are not making a noticeable impact on the incidence of heart disease. And, I think physicians are starting to wake up to that fact that whatever we're doing right now is not working, and we need to start considering some other ideas.
Yeah, I guess, what I've seen is, due to things like what you do, people survive heart disease more than others. But you say the incidence is actually not gone down at all. What are the current numbers looking like? How many people a year have suffer from these things?
Yeah, so in the United States, approximately 600,000 people die of heart disease every year. Like I said, it's the number one killer by a wide margin. You look at number two, which is usually cancer, and it's about half of that, about 300,000. And even last year, where COVID, was the number two, at slightly over 300,000, it was still half of what heart disease that kills, and it kills that many people every year for the past, 30 plus years. The overall incidence of heart disease is much higher. I believe the numbers are around, 1.5 to 2 million people will be newly diagnosed with heart disease in the United States every year. So it's a huge problem. And as you said, we're getting better at keeping people alive longer with heart disease. But ultimately, we're not changing the fact that, people continue to die at very high rates from the heart disease. So, all of these procedures that we do, these surgeries that we do, we can keep people alive longer, but we're really not changing the ultimate outcome. And I believe that's because we're not addressing the root cause ultimately. Whether you put in a stent, whether you do a bypass surgery, whether you put someone on medications to lower their cholesterol level, we are not addressing the root cause of the heart disease, the poor metabolic health and the inflammation that results from it. And therefore, we shouldn't expect to be making any meaningful impact on it.
Yeah, I mean, one of the things out there with regard to cholesterol levels is all-cause mortality. And we look at, there are a number of studies now that show that very low cholesterol is associated with increased all-cause mortality, including things like cancer, infectious diseases, neurodegenerative diseases, and people die of a lot of things, even though heart disease is clearly at the top. Do most cardiothoracic surgeons and cardiologists give a rat's ass if somebody gets cancer? I mean, it's not my not my deal. So you're good. Is that kind of the thought?
Yeah, that's exactly it. And that's the issue that we have in the healthcare system in general, is that we've become so segmented. Everyone just pays attention to their particular area of expertise, their particular problem, that we miss the pattern that, again, metabolic health has been associated with, 6 of the 10 leading causes of death in the United States every year. So, you look at heart disease, you look at cancer, you look at Alzheimer's disease, you look at diabetes, high blood pressure, kidney disease, all of these things can be associated with poor metabolic health. But because of the way that we're so specialized in medicine, no one is looking at the overall picture. And, again, that is what has been so powerful for me as I've kind of refocused on metabolic health, is that not only am I helping people to prevent heart disease, I'm helping them to prevent all these other issues as well. And I think ultimately, that's why we need to be better focused on this as a healthcare system and as individuals.
Yeah. So, I mean, the obsession with ultra low, cholesterol, some LDL cholesterol, some people point out, it should be below 70 at some point, that, may impact heart disease, but at the same time, you dramatically potentially increase your risk for all these other diseases. And so, but if you just focus on metabolic health, you can take care of everything. You can decrease your risk for cancer, you can decrease your risk for heart disease, stroke, infectious disease, all these types of things. What is, so this, how much success are you having, with getting people to change their lifestyle?
Yeah, so in my telemedicine practice, the patients that come to me that are trying to prevent heart disease or are in the early stages, I'm seeing great success, and this is a common theme when you talk to the physicians that are getting involved in, metabolic health, low carbohydrate, carnivore, all of that. It works very well. Patients, reverse their type 2 diabetes, get off their blood pressure medications. They, get to a healthy weight. I work with many men, who have low testosterone levels or are on testosterone replacement, and we fix their metabolic health and their testosterone levels improve and they don't need testosterone replacement anymore. All of these things are results that, those of us, those physicians that are doing this, we see these things every day. And, we're starting to get those published results into the literature, which is important. The data coming out of Virta Health, was very important data, and it showed that 60% of their type 2 diabetics were off medication with normal blood glucose levels at 2 years on their program. Guys like, Trokalasian, who's, more and more publishing, his experiences. We are seeing this more, and I see it routinely in my metabolic health practice, and I know the people in this community have seen those results. And ultimately, that is going to be the most powerful force that is going to, get this message to spread, is the individual results that people are getting.
How much, as you get into a specialized surgeon where, most of your days is, doing surgery, how much did you have to go back into basic physiology, basic medicine? Did you have to re-educate yourself on some of the stuff that you may not have thought about for, 30 years or something like that?
Yeah, there certainly has been some of that. Thankfully, I was curious enough to kind of start down this journey and to start asking these questions. When I saw my own personal success, and then I started wondering, why didn't I learn these concepts in medical school? Why don't we hear this talked about more? It prompted me to kind of go back and go through the literature and, learn about this. Many great books and podcasts and all the other, kind of resources that we have available to us these days have been helpful in that. But ultimately, the basic kind of physiology, that I deal with every day, the cardiovascular system is at the center of this. So, it wasn't so much a matter of relearning information. It was just a matter of, looking at it with a different perspective, without the biases that I think we had developed, through medical school and training in the early part of my career. It was more a matter of unlearning some of that information than having to learn new information.
How much, do you think you would have gone down this path had you not, suffered from illness yourself? I think you said you lost quite a bit of weight and, you probably had some metabolic syndrome. Had you not experienced that, do you think you would have just kept plugging away and never thought of it?
Yeah, I think going through it myself, having my own issues, losing, over 100 pounds and reversing my own pre-diabetes, certainly, accelerated that process. But, even before that, it did always bother me on some level that we were told that, cholesterol was kind of the singular cause of heart disease. And yet I was seeing lots of patients who didn't have high cholesterol levels, or that, it's all about obesity. And we were seeing lots of patients who weren't obese that I was operating on. So those types of things did, kind of start to, gnaw at me a little bit. But I think certainly, my personal journey was a big part in my professional journey. And it's interesting, how many of the physicians in the kind of low carb metabolic space that we interact with that give that same story. This started because they were trying to address one of their health issues. And then, they realized what a benefit it would be to their patients as well.
I remember when I was in, I think, medical school, and I had to do my cardiology. I think we did I can't remember, a week or two of cardiology, and we'd sit in on the rounds, and they would, they'd be there, and I think the CT surgeons might have even participated, but they would be going over, case reports and, talking about different patients, and there'd be a big box of donuts that everybody was eating, and the joke was, it's all genetic anyway, it doesn't really matter, and I think that's kind of the, main thought from a lot of these guys. How much does genetics play a role in this? Is it all genetics, or does genetics play a much lesser role?
Yeah, my take on the literature, on everything that I've learned, is that genetics play a very little role in this, very small role in this. And even, within cardiology, and genetics, it often comes around to, familial hypercholesterolemia. And these are patients with, a very high cholesterol level, from birth, essentially. And it's interesting because even when you look at that population, if you can take out inflammation, if you can minimize inflammation, a lot of those patients do not develop heart disease, despite having very high cholesterol levels for, essentially their entire life. And, so and that's rare, understand that that's, less than 5% of the population has familial hypercholesterolemia. So for the rest of us, really, I think genetics are, almost a non-issue. The reason that it seems that heart disease runs in families, that it's so common that patients that are coming to me for heart surgery now say, oh, my dad had heart surgery, my brother had heart surgery, is because families have the same habits. They grow up in the same environment, they eat the same food. And so, it looks like it's genetic, but I think genetics are a very small part of this ultimately. And even patients that truly have that genetic predisposition, familial hypercholesterolemia, even they will benefit from focusing on their metabolic health.
Yeah, I'm glad you pointed that out. That was one thing I was going to ask about, is if people with FH, should they, it seems to make sense for everybody. What, as far as decreasing cardiovascular risk, how rapidly can you de-risk yourself? Is it something that takes years, or can you do this quicker than that?
Yeah, so we know that you can start to see these metabolic changes in as early as 30 days. Guys like Rob Seifus have shown that liver, fatty liver disease can be improved, if not reversed, pretty quickly within 30 to 90 days. In terms of cardiac risk, again, we're really not necessarily looking to undo damage that's already there. We're looking to stop any further damage. The most common tool that I guess I use to assess, improve, lowering heart risk ends up oftentimes being the CAC scan, the coronary artery calcium scan. And, we might not see reversal. Like I said, we don't necessarily see lowering of the CAC score, but we see it stop progressing. Now that's something that we don't measure, on a weekly basis or every few months. It's usually 6 months or a year before, I'll get a repeat scan on someone. But we know that if, your CAC score does not increase significantly year over year, that puts you back into a low risk category. Even if your CAC score is elevated at baseline, if it doesn't progress significantly over a 1 year period, that puts you back at a low risk category. So it's hard to really say, how quickly are we reversing the heart disease risk per se, but we know that we can reverse poor metabolic health pretty quickly. We can make significant improvements in it pretty quickly. And therefore, we have to believe that that's going to, be lowering your cardiac risk as well.
How much, of what you're doing is insurance paid for? I mean, is this something that you have to struggle to get reimbursed for? Or how does that work?
Yeah, so for my telemedicine practice, I don't accept the insurance. It's outside the insurance system. The insurance system really doesn't have any mechanism for doing this, for dealing with it. I know a lot of the primary care guys that have gotten into this have gone this sort of direct primary care model where they don't deal with insurance because, quite frankly, insurance gets in the way of this. If you are largely dependent on insurance, that usually means that you need to be seeing a high volume of patients, so you don't have the time with each individual patient that this takes. And admittedly, this isn't as quick as writing the prescription for the medication. These are, detailed discussions that need to be had with the patients. There's, very detailed assessments that I, usually end up doing on these patients. So I have stepped outside of the insurance system for this. And, I think it would be very difficult to do this dealing with the insurance system on a day-to-day basis. Now, the interesting part of this is that ultimately it might be the insurance system that in somehow, ends up saving us all. Because ultimately the cost of taking care of these metabolically unhealthy people, the cost of diabetes, the cost of heart disease is bankrupting this country. And it's not just limited to the United States, it's actually a worldwide phenomena. And so I think, going through the insurance companies, demonstrating that you can save significant costs when you get these patients off of medications, get them off of the diabetes medications, prevent the complications that come downstream from that, and all the costs associated with that. That is ultimately going to get insurance companies interested in this. And, ultimately there might be a way to work within the insurance system. But for right now, I work outside the insurance system in my metabolic health practice.
One of the criticisms regarding, the assumption would be, well, the insurance companies would be all over this because they're saving money. But what my understanding is, the average consumer switches insurance every 2 years or something like that. And so what happens is they don't want to invest in prevention because the money they save will be for the next crew, the next insurance company. So they don't actually benefit themselves. So they're kind of, because of that high turnover, they're disincentivized to, kind of do that stuff. It's kind of interesting. I've got there's a question in the chat here, Phil, if you don't mind. There was a concern as to why HDL recommendations are higher for women than they are for men. Can you speak to why that number is a little bit different?
Yeah, basically just because women tend to have higher HDL levels, in general. So what has been found to be, sort of an adequately healthy level, a high enough HDL level ends up being higher for women than for men. One thing to say is, those measurements that I gave are the official metrics, in that study that, I talked about, that only 88% of, or that 88% of adults are not metabolically healthy and can't meet all 5 measures. Those were the criteria that they use. I think a better measurement when I'm working with my patients, I aim to have their triglyceride to HDL ratio be less than 2. That's really the metric that I more commonly use. But the official, metrics from that study were HDL level over 50 in women and over 40 in men.
When you're adjusting, let's say, your numbers aren't where they want to be. Let's say your man and your HDL's 27 and, your triglycerides are 200. What's the most impactful thing you can do to change those things?
Yeah, so diet is number one. When we look at triglycerides, it responds pretty quickly to lowering your carbohydrate intake. HDL also will come up, significantly when you lower your carbohydrate intake. Eliminating vegetable and seed oils seems to be another, significant factor in raising HDL specifically. and high levels of omega-3 intake, fatty fish, raises HDL as well. And then finally, the other factor that goes into HDL in particular is the amount of muscle that you have. And when I see people building muscle mass, doing resistance exercises, that their HDL level tends to come up as well.
My understanding is HDL, particularly in males, has a more of a stronger genetic component than perhaps in females. Is there some, am I imagining that, or is there something to support that?
Yeah, there seems to be kind of a range. I think that, your genetics may have some effect on, kind of the range that your HDL will be within. But it's still a fairly significant window that I think most people have the capacity to, move their HDL within. And I think improving your metabolic health is going to raise your HDL cholesterol level. And yes, some people might not get as high as others, but I haven't really encountered someone who can't get it into the healthy range, at least, over 40 for a man, over 50 for a woman. Turns out to be kind of a metric that I think anyone can get to when they focus on their metabolic health.
Yeah, have you found that well, let me ask you, do you find any other, a lot of people are looking at different things now, like things like LP little a and, LPIR scores, which is part of that women's health study that you mentioned. Are you utilizing any of those other things in addition to the 5 things you talked about?
Yeah, so,
is there any utilities that add?
I think it can help, better refine the risk question around heart disease. So, obviously, even though I try to be broadly focused on metabolic health, ultimately, many people find me because of my background in heart disease. And I think those cholesterol, advanced cholesterol measurements, whether it be the NMR panel with the particle size, things like LP little a. Now we can actually measure the amount of oxidized LDL cholesterol. Those measurements can all help to kind of, it really comes into play when, we get those patients who are metabolically healthy or are improving their metabolic health, and their LDL cholesterol level is high, and they've been told that that puts them at high risk. And so these other things, can be looked at to kind of better refine that risk, equation, I guess, as we could say. Ultimately, it ends up being more reassurance, I think, for most people, because they're at low risk by all these other factors, and we're just dealing with an elevated LDL cholesterol. But I do end up looking at them a lot. I think it's important, that you're working with a physician who understands that. Because ultimately, when we get back to the, cholesterol, the LDL question, I think, just looking at the LDL cholesterol to try and determine your heart risk and trying to make decisions about whether or not you need to be on statins or something like that is not enough information. I do think you need to look at these other factors. You need to get a more complete assessment of how much risk you're truly at. Than just looking at one simple measurement, the LDL cholesterol.
Perfect, Phil. We only have a few minutes left, so I want to make sure. So once again, where is your book available? Is it online? Where can you order it?
Yeah, so again,
how do you get a hold of it?
Stay Off My Operating Table. It is on Amazon and all the other major online platforms at this point. Barnes & Noble, it's in Apple Books, iBooks, all of that. It's got a Kindle, it's got an audiobook, and it's got the print version. If you go to my website, ovadiahearthealth.com, OVADIA hearthealth.com. It's got all the information on the book. It's got the information on my practice. Again, I have a telemedicine practice that is based out of Florida, but I work with patients all over the country, all over the United States. And I also have a group coaching component to my practice that's available for people who I might not be able to work with geographically or for other reasons. So all that information is at the website. And on social media, the best place where I'm most active is on Twitter at iFixHearts. But as we all know, that could be taken away at any time. So go to the website, sign up for my newsletter so you can kind of follow me, wherever I might end up heading to next.
Awesome, Phil. Thank you so much for being here, and good luck with the book, and thanks for continuing to do what you're doing. And I will, when I get into Tampa, I will send you a little text to let you know if we have a chance to meet. So that'd be awesome.
Sounds good.
Okay.
Hopefully we can meet up in person, Sean.
Okay, guys. We'll talk to everybody tomorrow. Take care, everybody. See you later, guys.
Join Revero.health for a 30-day free trial to get access to live Q&A with VIP guests, social community meetings, member discounts, low-carb healthcare providers list, forum, workouts, monthly challenges, early access to podcasts, recipes, carnivore diet guide, fasting guide, shred guide, and much more.